Thanks very much. So my name is Deirdre Murray. I'm a physiotherapist at the Motor Neuron Disease Clinic in Beaumont Hospital in Dublin. And I stood on this side of the stage to get as far as possible away from my Irish colleagues who plan to heckle me throughout the entire presentation. So I'm here to talk about spasticity, so just one of the myriad of challenges that our patients can encounter on their journey. And if we look at the actual definition of spasticity, it's a motor disorder characterized by a velocity-dependent increase in the tonic stretch reflex. And you can see there that you've got this classic presentation where if you move slowly, the limb has a good range of movement, but when you do a fast movement, you get that fast catch. Now, this lady doesn't have ALS or PLS. This lady has MS, and this is what you see as a very classic presentation when you assess in a patient like that. And our PLS and ALS patients aren't always as clear as that when you do a bed assessment. What we're dealing with a lot of the time is assessing a hypertonia, so an increase in tone that is probably most apparent during function, actually, rather than during a physical assessment. But it's always important to remember that you've got a neural component, so that's driven by the nervous system, and then you've got the biomechanical component. So just because of immobility and inactivity, you can have just muscle stiffness that can develop that you also have to manage. In our MND patients, there are this ALS, generally spinal onset patients that present with a mixture of upper and lower motor neuron symptoms, so our progressive muscle weakness with some spasticity of varying degrees in different patients. But most often it's the PLS patients that are much, much fewer, and we don't see as many of them. But these are the people that really present with quite significant and profound spasticity that leads to a long, long period of dealing with significant levels of disability. If we look at the evidence and the guidelines, the European guidelines recently have recommended that you need to start with your non-pharmacological interventions for spasticity, so physiotherapy, exercise, etc. And that's mainly what we would be focused on as health and social care professionals, OTs, physios generally. But then that you can use the pharmacological interventions, so cannabinoids, baclofen, things like that, and things like botulinum toxin if needed. And the Canadian best practice guidelines, since this is where we are, and they're also very recent, similar kind of recommendations there that you can use stretching, but a low level of evidence. There is a kind of just maybe consensus around using the pharmacological interventions, and that there isn't sufficient evidence for using things like intrathecal baclofen currently. So the question is, just because somebody has spasticity and presents with it, why should we treat it? So you don't always have to treat it, and that's a really important aspect of making a management plan. And particularly physiotherapists and occupational therapists are very well placed in the decision-making process as to whether we actually need to treat this spasticity or not. So if the spasticity is causing difficulties with function, mobility, skin breakdown, hygiene issues, and pain and discomfort, they would be the types of indications for actually treating the spasticity, but always bearing in mind that sometimes spasticity can be useful. So if you've got extensor spasticity in your legs that allows you to stand and transfer despite weakness that you also have there, then it would be wrong to treat that and to possibly make function worse. So we're very, very well placed as the people who are doing these kind of hands-on mobility and function assessments to be the ones that would guide decision-making around whether we intervene or whether we kind of are happy with the status quo. So overall, with spasticity management, it needs to be multidisciplinary, it needs to be multifaceted and goal-orientated, and that's very, very important that we're developing goals as to what it is that we're trying to achieve by coming up with an intervention. In Ireland, because we're a small country, we often piggyback on all the hard work that happens over in the UK, and we would refer quite often to things like the NICE guidelines, and this management algorithm comes from spasticity management for adults that was developed in the UK, so the RCP guidelines, and is a really useful algorithm to guide an intervention. So this is something that I would recommend looking at if you're not familiar. And it starts with the basics, so your physical interventions, so the bread and butter stuff that physios and OTs would do, and that's your starting point. Things like if you've got exacerbating factors, so if you've got somebody who's got discomfort or pain, issues with clothing, a leg bag, pressure sores, constipation, all of those kinds of things, before you go crazy with pharmacological interventions, you need to make sure that you've got all these things sorted first. Really basics around positioning, so I'm not sure if I have the best pictures there. I probably have a few OT colleagues in the audience there who are not very impressed, and some of this is obviously targeted towards stroke, but you get the idea. Positioning is so important. Other types of simple interventions then that we can use are things like splinting and casting. So, I mean, I would rarely cast one of my ALS patients, but certainly the simple off-the-shelf splints or modified hand splints, prafos to maintain range of movement at the ankle and things like that are very useful. And then exercise. So exercise, as we've heard earlier today, is so important and should always be figured out as to some level of exercise that the person can do that may be beneficial to help to keep their range of movement, keep their strength, manage spasticity. The evidence is very limited, but we do have some indications that things like using these kind of active passive trainers are found beneficial by patients. So the Meyer in Germany did a very pragmatic study where patients were using active passive trainers and they just asked them, do you think that it is helping you? So the majority felt that it eased the feeling of having rigid limbs, or it reduced the sensations of muscle stiffness. So in the absence of being able to do a randomized controlled trial and something like that, I felt that was a very pragmatic way of assessing the impact. So this type of thing is really important. Pedaling is really nice for lower limb spasticity. Stretching is generally accepted as being important and is kind of always the first go-to that's referred to as regards to treatment. But we don't really know the dose duration, the ideal situation. We do have some evidence that stretching in combination with botulinum toxins is beneficial more than just botulinum toxin on its own. So stretching is always a good idea. Once you've kind of got all of your basics in place and you've maximized those, then you do start having to think maybe about some pharmacological interventions and discussing the need or the role for these with your medical colleagues. And I would often, I suppose, initiate these conversations in our clinics with our doctors as to, maybe adding in a little bit of a pharma treatment would be helpful for our patient. So if you've got a very generalized spasticity, the kind of go-to are things like baclofen, tizanidine and things like that. Unfortunately, we don't have any access to Sativex in Ireland because we're not allowed any kind of cannabis at all, so it's different here. The key thing with these medications is that you need to start low and go slow, because people can have side effects, people can feel a little bit weak, people can feel fatigued, and you just need to very carefully titrate up and down and consider a mix of drugs. And again, if you're the physiotherapist or the occupational therapist and you're maybe in more frequent contact in assessing patients, you might be a well-placed person to initiate the conversations with your medical prescribing colleagues as to any titrations to these medications. There has been one small study looking at intrathecal baclofen in people with PLS. It's not currently supported in the guidelines, and I haven't actually met a patient from our clinic who has had an intrathecal baclofen pump, but it is something that if you've got very severe regional spasticity, so very severe bilateral lower limb spasticity, is something that you could consider. And what can be helpful if you have a focal spasticity, so that's spasticity in a particular muscle or muscle group that is causing particular problems that you can target with a functional goal. This is something that can be quite helpful. So this is very widely used in stroke and MS, limited evidence in ALS and PLS patients. There's different kind of preparations of botulinum toxin, and very little evidence in our ALS, PLS patients. So we've got kind of two kind of small cohort studies there that found improvement. So it's probably a little bit different in different countries around the world, but in the UK and Ireland, as a physiotherapist or an occupational therapist, you can do advanced practice training and you can become an administrator. In the UK, they can prescribe as well. We can't prescribe in Ireland, but I did some additional training so that I could administer botulinum toxin. And I suppose the motivation for that is that we like, when we identify a need in our patients, in our clinic, we want them to get it as soon as possible. We don't want to be referring them off to another service where there's, a 6 or 7 month wait. That's no good. If we decide somebody needs something, we want to have control of it ourselves and we want to do it now. So I have a very small little cohort of our patients that if they're identified as being somebody who may benefit from administration of botulinum toxin, I can do it in our clinic. So I had to do a load of extra training. And when you've been a physio, as I was 10 years ago, and I trained this for 15 years, and you have never done any kind of sticking needles in anybody, it's a bit of a heart attack to suddenly turn around and start, this is what you're doing and all the risks associated with it. So I've just got a couple of case studies then of the types of patients that would kind of go this route in our clinic, and hopefully the video works again. So I've got a couple of videos here of people who have adductor spasticity. So this is really, really common. One of those cohort studies purely focused on this adductor spasticity. This gentleman has spinal onset ALS with quite a lot of lower limb spasticity. His adductors, you can see the scissoring gait are a particular problem. This lady is much more mobile than he is, but has that significant adductor spasticity. It's very annoying for her, like her legs are crossing with every step. And this gentleman here is kind of more, he's weaker, he's further down the line, and you can see he's so weak around his hips, but the adductor spasticity is very problematic for him. So as a kind of a case study, there was so many examples of the adductors, I put loads of videos in, but I'm going to talk about the lady with the white trousers, who was quite a bit more mobile. So her problem was slow walking speed, her legs were crossing, lots of effort associated with walking. Our outcome measures were we measured gait speed and we measured her abduction range of movement. And the goals were that we were going to try and get a little bit of an increase in her walking speed, get a subjective increase in her ease of walking, and improve her ability to stretch her adductors easily. So there was 100 units of Botox administered to just her left adductor. So we'd like to kind of start with the minimal amount of muscles and the smallest dose that we think we'll get away with and take it from there rather than going mad. And then the follow-up was adductor stretching, hip and glute strengthening, a little bit of gait re-education. So the outcome of that was that she felt a reduction in the effort of her walking, her gait speed increased a little bit, not quite the 10%, but not far off it. She was managing her stretching very well, her range of movement in her abduction increased by about 10 degrees, and she was happy then at the 4-month mark when the toxin had worn off, that she was keen to kind of try again and maybe add in the other leg and try it, so you kind of take it incrementally like that. Now, the audio may work on this, so if it doesn't, I'll talk through it. But
here we have a foot and ankle that has quite severe calf and tib post spasticity. So from the point of view of the calf, there's a lot of loss in range of movement. We bring it into midline, probably at about minus 40 degrees there. There is some clonus in the calf, and you can see the way that it rests, pulling into inversion. So that's tib post overactivity as well as weakness in the everters. And you can see that there's also some clonus there in tib post.
So quite severe calf and tib post spasticity there. And the problems for that gentleman were that he had very painful calf spasm, disturbing his sleep, difficulty getting his feet positioned on the footrests, difficulty getting comfortable position in bed. His ankles were painful because he was pulling so much into inversion. We measured his spasm frequency, his pain, his ability to position his feet on the wheelchair, ankle range of movement. And the goal was to, really the main goal for him was that he would get a good night's sleep with it. I mean, there's enough reasons to be woken at night without being woken with calf spasm. So he had some botulinum toxin to both calves and to that left tibialis posterior that was really pulling in and causing problems. He had an off-the-shelf Prafo that he was tolerating for about 3 or 4 hours, and an A60 splint, so a really light, simple little splint that just kind of helped to maintain his ankle a little bit more in midline when he was wearing his shoes and sitting in his chair. So the outcome of that about 6 weeks afterwards was that his spasms were completely gone. So this is a really, really effective intervention for this type of calf spasm. He wasn't waking up because of spasm. He was much more comfortable in bed and he felt his feet were better positioned on the footrests. And then at the 4-month mark, he was very keen to come back. He was looking forward to his visit where he got more needles stuck in him. This is a really nasty example of an unusual pattern of spasticity in this person's wrist. I think the video should work there now in a second. So terrible swan necking of his fingers, and most of this was being driven by his wrist flexors. So this was a very painful wrist, difficulty getting his arm through a sleeve. So every time somebody tried to dress him and get his arm through the sleeve, it was really painful if there was any movement there. So we measured wrist range of movement. The goal was to improve the resting position, make it possible maybe to apply some kind of a resting splint and improve that pain during dressing. So we targeted those wrist flexor muscles, and he had a moderate improvement in pain during dressing. So the conclusion really is that healthcare professionals, especially the physios and the OTs that do a lot of this kind of hands-on assessment, are very well placed to guide spasticity management. Goal setting and being very clear about the reason for treating the spasticity is very important, and it's very important to evaluate the outcome of your intervention. So I just want to say thank you to my MND team in Beaumont Hospital who's refrained from heckling me, and the patients who agreed for the videos to be used for the presentation. Thank you.
Thank you so much. I was really just sitting there paying attention and was like, oh, I'm supposed to go up there. Because I just thought it was such a fascinating presentation.
Thank you.
So let's see if there's any questions out in the audience.
I think everyone just wants to go home maybe now. It's hard to be second last.
Her teammates don't have questions for her? So when you're doing, where? Oh, all the way over here. Just yell, Katie, yeah. Sarah.
Okay. I'm wondering, sorry. I saw a poster at Neil's where they're using TENS to manage spasticity, and I'm wondering if you've done that.
No, I haven't used TENS. TENS, you'd use it for pain management, certainly. So if there was some pain associated with the spasticity, TENS would work. Sometimes in stroke, you would use more electrical muscle stimulation in the opposing muscles, maybe to kind of attenuate spasticity a little bit. But really, TENS would be just for comfort and pain management. I don't think TENS would be great for really getting rid of those nasty spasms. I don't think so.
Thank you.
Anyone else? When you do the dosage of the Botox, how soon after that do you start the stretching and all the therapy? Like right away that day within a...
Yeah, so I mean, well, what we were taught anyway was that once you inject the Botox, it's good to get the limb moving to try to get, because what you want is that the toxin disperses within the muscle. So to try to make that happen, you want a little bit of movement, and people would just start stretching and doing whatever pretty much straight away. There would be no reason to wait, really. So yeah, you want the toxin to disperse where you want it to be, and then you'd kind of reassess at typically 6 weeks is the point where you're going to be at max effect to know whether you achieved your goals and you got the outcome that you wanted, and whether you should, titrate up the dose or add in a different muscle and things like that. Yeah.
There's an online question.
Sorry about that. Online question from Timothy Shea from Calvary Healthcare Bethlehem in Australia. He says, great talk. Do you ever inject for spasticity in the neck, e.g. resulting in the head dropping to the side?
I personally haven't injected necks. I'd be a little bit like, I am just the physio. I kind of like to stick with the arms and legs until I'm building up my confidence a little bit more. There'd be a little bit more risk with injecting necks because toxin can disperse around a little bit, and there can potentially be impact on a swallow. I have had one MS patient a few years ago that was injected by a medical colleague and lost her swallow after having, now he put in a much bigger dose than I would ever have put in, to be honest, but into her traps, and the swallow was gone the next day. But so I'm a little bit more wary of the neck, but we have had a patient that we sent to the kind of spasticity clinic that for more complex patients, that it was for kind of a neck that was flexed to the side, very painful, really difficult to manage neck. And again, they decided not to inject it, but we actually ended up managing that man's neck tightness and spasm with kind of really simple measures like heat, positioning, massage, and actually that kind of settled it adequately for him without going the toxin route. But I mean, it would be an option, but I'm not brave enough to do that myself.
Hi.
Humanji?
Hi, I'm
Where are you?
here. Yeah. So,
Oh, back there.
my question is, how often do you inject? How often?
How often?
How often? Typically 4 months. Yeah, it tends to last for 3 to 4 months. And I like to ideally wait until about the 4-month mark, because I want, when my patients come back to me, I want them to say, yes, I noticed it wearing off. I can see a difference. I really want it again. So, you know, if you re-inject at the 3-month mark, you've probably got a little bit of still of the effect from the previous one. And every single time somebody comes, we reassess and make sure that this is definitely indicated still. Because the last thing you want to obviously do in ALS, MND, or even PLS is to be injecting a muscle to weaken it when it's not needed. So you're quite careful that somebody definitely still needs it.
Thank you.
All right. One more question, then we're going to have to move on.
Hi, Ileana Howard from Seattle, Washington. I want to say thank you for the talk. We know that spasticity is very common and one of the most undertreated symptoms. It's something that we can treat to improve comfort and quality of life for our patients. Just 2 quick comments. One, in our clinic, we use intrathecal baclofen pumps for patients with upper motor neuron variant or primary lateral sclerosis, and it's life-changing for those patients. So I find that to be a very useful tool. And the second one, for medication management, I would just add benzodiazepines. We don't use them a lot for our other patients, but in patients who may have more than one symptom to manage, including spasticity, a low-dose benzo can be very helpful as well.
Yeah, that's definitely true. Thank you. And it's very interesting about the intrathecal baclofen, because there just isn't that much in the literature about it, and certainly the Canadian guidelines say that there isn't enough evidence at the moment. But we actually have a lady, an inpatient at the moment, and they're going to put one in because there's nothing else that's really adequate for her. So it's definitely there as an option. Yeah.
All right. And do you have after videos for some of those people?
Do I have?
After videos? You have the before video. Do you have after?
Yeah. The problem was having to have it all uploaded by the 4th of November. So.
We blame Jess. All right. Thank you so much.